Today's topic is laparoscopic instruments. In laparoscopic, in any instrument before in examination part during Viva, we have to discuss about uh, 5 things. First is name, then parts, uses, complications, and its sterilizations. We have to discuss, or they will ask you about these 5 points in describing any instrument in Viva. First instrument is Veris needle. See, this one is the Veris needle. The Veris needle has mainly two parts. I will discuss the instrument first, and then I will go to the theory part. See, this has two parts. One is I will rotate it and remove it. There is an outer part and an inner part. The outer part is the needle. So needle has a cottage. This needle has a, see, this is a cottage and this is sharp. This will enter into the skin. But the inner part is called stylet. So this one is the stylet. The stylet has a blunt tip and see an eye in near the end. See the eye. This eye is for inlet of the entry of the gas, and this is the point where we attach the gas pipe, and there is a spring at the center. See, this is to open and close the valve. This is the valve for the gas. See, the needle goes inside the stylet goes inside the needle, and we close it. Okay. So there is a spring action. It has two action. One is spring action. The spring action has its significance because when you enter the skin, the sharp cottage of the needle will come outside, will enter into the skin, and when the resistance is lost, then because of the spring action, the blunt tip come outside. So it will prevent the visceral bladder injury, bowel injury, and vessel injury. And there is a hole for the eye for the inlet of the entry of the gas. So this is the blunt tip, but the sharp edge that will help in the entry into the skin of the needle. So outer part is the needle and inner part is the stylet. So, and from the stylet there is a gas valve. So I will rotate it. See, if it is perpendicular to the inlet, then it is closed. If it's parallel to the inlet, then it's open. Okay. So, see, this one is the needle. The outer one is this is the cutting edge of the needle, and this is the cutting edge, and this is the blunt tip of the stylet or inner cannula. So this is an eye for entry of the gas, and here is the spring part, and this is the valve for entry of the open and close. So this is the valve. If it is perpendicular, then it is closed. If it is parallel, then it is open. Okay. Next is how to hold it. It has mainly 4 sizes: 8 cm, 10 cm, 12 cm, and 20 cm. The 8 cm is for mainly babies or pediatric cases. 10 and 12 is for adult, and 20 cm is used in bariatric surgery, obesity. So because of the obesity, there is deep layer of fat. So to entry into the abdomen, we need a long needle that is 20 cm for bariatric surgery. How to hold it? Every time you hold it like a dart. Dart means aiming aim. So the 4 fingers will rest on the instrument and thumb will approach. So this finger that will prevent the inadvertent entry into the abdomen to prevent the injury. So how much length we should leave? We will hold the abdomen just like this. We will hold the abdomen and add 4 centimeters. So this is, suppose this is the abdominal wall thickness. We will hold the abdomen like this and add 4 centimeter. So this much length. Suppose the abdominal wall thickness is 4 centimeter, and we will add 4 centimeter. So total is 8 centimeter. So we will leave 8 centimeter from here and we'll hold like this. That means this much part will require to enter into the abdomen. So every time we used to entry, there will 3 puffs. 3 puffs means why? Because there are 3 puffs. So this is, suppose this is the skin layer. This is the anterior layer of the rectus because of the fusion of the internal and external and internal oblique muscles aponeurosis, and there will be here there will be muscle layer. Okay, and below there will be another layer of rectus. So this is the first sound. We will get aponeurosis of the internal and external oblique. Then second layer of aponeurosis is the second sound. This is the second layer of aponeurosis. This is the first layer of aponeurosis, and third will be the peritoneum. So when we will entry like this, so we will get here one puff sound, here another puff sound, and here another puff sound. So 3 puff sounds will have. But at the level of umbilicus, how many puff sounds will be there? At the level of umbilicus, there will be 2 puff sounds, because at the level of umbilicus, all the fibers, aponeurosis fibers, external oblique, internal oblique, anterior and posterior, both are fused together. So we will get, one entry here and another entry at the peritoneum. So we will get 2 puff sounds. One is here, another is here. So 2 puff sounds at the level of umbilicus. Okay. Next is how to check the correct placement of the vessels. Suppose there are few signs. Then I will tell how will you entry technique. The few of first sound is, I'll tell, you told you double click test. When you enter the rectus and peritoneum, there will be 2 click you will feel. The first is double click test, or so 2 clicks will be felt by the surgeon. That is the first sign. Second sign is aspiration test. When you enter the abdomen, before using this instrument, we have to check 2 things. One is the spring action and whether spring is okay or not. We have to do like this. See, the spring is okay, and we have to check the patency of the tube. How will you check the patency of the tube? We will take 2-3 ml of some normal saline and we will insert it and push it. So if it is if the patency is okay, we will see the normal saline is coming out. Okay. Then after entering into the abdomen, first suppose I have entered into the abdomen. Now I will take 2-3 ml of normal saline and first I will aspirate. Suppose, why aspirate? Because if your instrument is inside the blood vessel, so it will red or blood will coming out. If it is in bowel, then yellow or fecal matter will come out. If urine is coming out, then think you are in the bladder or there is some ascites. So to diagnose first any perforation or injury into the visceral structures, so we will first aspirate. Then if nothing is coming out, then we will push some amount of normal saline. That is called irrigation test. By irrigation, suppose some amount of fat or anything will be blocked here, that will be clear. And again we will aspirate. If the amount of fluid we have irrigated into the abdomen, then if it is not coming back, we will push it 2 ml. But if it is not coming back, then you are sure that you are inside the peritoneal cavity, because see, this is the abdomen and this is the peritoneal cavity. So if you are entered into the abdomen and will push 2-3 ml normal saline, but this amount of fluid will not coming back because you are in the peritoneal cavity and it is not a closed cavity, it's an open cavity. Suppose some cases, what happens? You are in the not in the peritoneal cavity, you are in the pre-peritoneal space. This is the peritoneum and this is the abdomen. So if we will push some amount of fluid, the fluid will be here and we will aspirate again. So if the same fluid is coming back, that means we are not in the peritoneal cavity. Okay. Next is hanging drop. After this, we will remove this and put some amount of drop here, and we will lift the abdomen. if the normal saline drop is going into the or sucked into the abdominal cavity, then the hanging drop test is first step. That means you are placed the needle inside the abdomen correctly. Next, most important sign is, it is the confirmatory sign is intraperitoneal pressure test. We will attach the gas. Suppose this is a gas tube. I will attach the gas tube here. I will attach the gas tube. Then suddenly on the insufflator machine, I will see the amount of pressure. If it is less than 10, the amount of pressure is less than 10, that is the most reliable test. That is the intra-abdominal pressure with CO2 will be shown. If it is less than 10, that means you are confirmed that you are inside the peritoneal cavity. Next is plunger test. What is plunger test? In plunger test, we will take 2 to 3 ml of normal saline. I am not taking it because it is not. So we'll take 2 to 3 ml of normal saline and remove the plunger. Then we'll lift the abdomen. The water column will gradually coming down. Then that means you are inside the peritoneal cavity, because there is negative pressure inside or less pressure, outside pressure is more. So the water column will gradually going down. So that is plunger test. If these signs are present, that means you are inside the peritoneal cavity. So this is most important question asked in Viva. Next important question is entry techniques. What are the entry techniques? So the peritoneal access in laparoscopy, it has one is closed entry, another is open entry. Open entry is called Hassan's technique. Closed entry means there are 2 types of closed entry. One is, first is we will give skin incision and we will put the varus needle first. That is the most commonly used. We will put the varus needle, then we will create the pneumoperitoneum. The gas will be insufflated into the abdomen and we will create the pneumoperitoneum. The abdomen will be distended. Then we will insert the primary port. Okay, this is called as closed entry. This is the most common type of entry we are doing. Another is we will do the skin incision and we will direct trocar insert. So trocar will be, before doing a varus needle, the trocar will be inserted directly. So that is called direct trocar insertion, and we will create pneumoperitoneum then. So that is called direct trocar entry. Next is Hassan's technique. In Hassan's technique, suppose there is some previous multiple surgeries are there, previous supraumbilical adhesions are there. So we will do Hassan's technique. We will give skin incision and we will give a long incision. We will separate or dissect the anterior sheath, posterior sheath, and peritoneum is incised. Then the primary port is inserted. That is the Hassan cannula. It is a different size of type of cannula, and then pneumoperitoneum is created. And the extra length, so we will put the cannula. The extra length will be temporarily sutured for during the surgery. So this is the Hassan's technique. So this is see, direct trocar entry is another method. If you are more expert in laparoscopy, so you can do direct trocar insertion. So one advantage is the rate of failed abdominal entry are reduced because of the direct trocar entry as compared to varus needle entry. But the risk of vascular injury and bowel injury mostly similar because of the direct trocar insertion and varus needle insertion. Another method is open entry or Hassan's technique. So this is the Hassan's cannula. See, there is another this part is to prevent the gas leak or any gas leak. Then in case of previous surgery or adhesions, we will do Hassan's technique. The disadvantage is greater leakage of the CO2, larger facial defect, and increased operating time because of this Hassan's technique. Next important question, this is also very important slide. What are the sites of entry? One is supraumbilical, the most common site. This is the umbilicus. We will do either supraumbilical, this part, or infraumbilical, or at the base of the umbilicus, superior base, inferior base. Next important point is Palmer's point. Palmer's point, the most importantly asked question in Viva. Palmer's point, Li Huang point, and Jen point. They will ask mostly these 3 questions. palmar point is, so this is the 9th intercostal space. So 3 centimeter below the 9th intercostal space at the mid clavicular line. 3 centimeter below the intercostal space at the mid clavicular line. So this is the mid clavicular line. This is the mid clavicular line. So at this point, 3 centimeter below the mid clavicular line is the palmar point. So in which case we will do palmar point? Suppose there is a previous surgery at this previous multiple surgery, or there is any umbilical site adhesions are there. Multiple surgery adhesions are there, then you will do the palmar point is safe because there is here stomach is there and spleen is there. So two contraindications of the palmar point. Contraindication from palmar point will be previous gastric surgery or splenic surgery. These are the two contraindications where we will not do palmar point. Palmar point is the another most safest point. Next is Li Huang point. Li Huang point, that is just below the episternum. Li Huang point. This is done in case of enlarged uterus, huge myoma, large ovarian cyst. So if there is a huge ovarian cyst, so we cannot do umbilicus because it will be perforated. So we will do Li Huang point entry. Next is Gene point. The placement of Gene point is important. Gene point is, so first we will take 2.5 centimeter medial to 2.5 centimeter medial to anterior superiliac spine. Will draw a perpendicular line. Will draw a perpendicular line. Sorry for my handwriting and drawing. Another point will be line will draw at the level of the umbilicus. So the meeting point of these 2 points will be the Gene point. So Gene point is the meeting point of one line is drawn perpendicularly at the level of 2.5 centimeter medial to ASIS. Another is at the level of one line drawn at the level of umbilicus. So the meeting point will be the Gene point. So in which cases we will do Gene point entry? That is the contraindication to the palmar point entry. In case of splenic surgery, gastric surgery, previous left paramedian incisions, colostomy or drain sites, and bones and keloids on the left side. Next is how the patient will be positioned during a varus needle or trocar entry. The patient must be supine position during varus or direct trocar insertion. So this is the most important point. Supine position, not traineal position, because during traineal position the aorta will be come up. So you will directly enter into the, there will be aortic injury or vena cava injury. And the patient anterior abdominal wall should be at the level of the waist level for the surgeon, and bladder should be drained, because if we will go like this, we will directly injure the bladder if the bladder is distended. So only supine position should be taken, not traineal block position, only supine position. Then coming to the most important is how you do direction of entry. The direction of entry, so see, this is the skin and this is the abdomen. This is the vertebral column and here is the aorta. Here is the aorta. Aorta is divided mostly at the level of the umbilicus. Aorta in normal patient, aorta is mostly at the level of the umbilicus. In very thin patient, it is 2 to 4 centimeter just below the aorta is 2 to 4 centimeter just below the umbilicus in very thin patient. So the direction of the entry should be always towards the anus. So you will be directing 45 degree. The direction should be 45 degree. most important thing is there will be two directions. One is to the skin and into the inside the abdomen. So if you will directly go 90 degree, then you will injure the aorta. So the direction should be at a level of 45 degree. Suppose in case of very obese patient, so this is this much of fat is there, and this is the abdomen cavity. So if you go 45 degree, we will never reach the abdomen. So for that, the rule is, so there is one is horizontal movement, another is vertical part. So if you go 90 degree vertical, so you will injure the aorta. If you completely go 45 degree, you will never reach the abdomen. So you will inside the subcutaneous fluid. So that's why the direction should be perpendicular to the skin, and inside the abdomen it should be 45 degree. So how will you maintain it? So you hold the Venice needle at a 45 degree angle, and we will lift the skin. We will lift the skin. So we will lift the skin. If I am lifting the skin, the Venice needle is pointing 90 degrees to the skin. So I will directly puncture into the skin. And also my direction inside the abdomen is towards the anus of the patient. So as my direction is towards the anus of the patient, so I will never hit the right. So I will go into the sacral curve. So sacral curve is the safest place. So where will you get the entry? See, this is the sacral curve. This is the sacral curve, and this is the aorta. Aorta is wiping the curve. So if you will entry like this, so you will never hit the aorta, never hit the aorta. Momentum or magnet will go into bowel. If sometimes somewhat, if you injure the bowel will be pushed downwards because the tip is blunt. It is not sharp, it is blunt tip. So because of the hollow sacral curve, the bowel will be pushed downwards. So it will not injure the bowel that much also. Suppose you will you are going perpendicular, then you will directly injure the bowel and the aorta. So direction should be always to the perpendicular to the skin and towards the hollow sacral curve, that's towards the rectum or anus of the patient. That is the most important thing. And in case of morbid obesity, you go transumbilical. That is the safest point, because in obesity the umbilicus goes downwards in that patient. So bifurcation will be mostly here. The aortic bifurcation is at the level of the L4. So in case of morbid obesity, the skin fat goes down, so umbilicus will be much lower than the aortic bifurcation. So you will never hit the skin. So you will turn umbilical in case of morbid obesity, and you will not hit the aorta. Okay. Sometimes what happens? We will enter into the abdomen, and before confirming it, we will inflate the gas. So inside the pre-peritoneal space, so this is the peritoneum, and this is the peritoneal cavity, and this is the pre-peritoneal layer. So sometimes we are putting the Veress needle or trocar, and we are in the pre-peritoneum, and we will distend the gas or inflate the gas. We will create the pneumoperitoneum, thinking that this is the abdominal cavity. So the pre-peritoneal space will be enlarged, and when we will do the trocar, we will reach the abdominal cavity. So this is another complication. So what are the uses of the pneumoperitoneum? Uses of the Veress needle. One is creating pneumoperitoneum during surgery, diagnostic surgery, laparoscopic operative surgery. Huge ovarian cyst aspiration can be done by this, because of this needle, or dermoid cyst aspiration, and for port closure also. During Hassan technique or 10 mm port closure, we can use this instrument to close the port. So thread will be inserted here inside this, and we can do port closure. The sterilization by 2% glutaraldehyde, side X, we are commonly using. Then coming to the complications. Most common complication is failed entry. Failed entry means we are not reaching into the abdominal cavity. So we are either reaching in the pre-peritoneum or subcutaneous fat, and multiple punctures are there. So we are creating gas inside the pre-peritoneal cavity. So pre-peritoneal cavity will be enlarged. So I am not reaching up to the, when I am doing putting the trocar, I am not reaching the abdominal cavity. So for failed entry, we have to do better is direct trocar entry. Direct trocar insertion has more success rate than only varus needle entry. Then coming to vascular injury. Suppose sometimes we have injured the vessel. So I have put the varus needle and now I am aspirating. So I am doing the test. I have put the varus needle in the abdomen. I am aspirating. So suppose blood is coming out. That means I am inside the blood vessel. So at the time, what to do? Suppose patient is stable and you have expertise in laparoscopy, then you can do another diagnostic laparoscopy, or you can, the patient is unstable, then you can directly do immediate laparotomy. First thing is any injury. First thing is any vascular injury, bowel injury, and bladder injury. First thing is leave the trocar, leave the needle at that place. Do not remove it. Do not remove it. Once you are removing, you are removing the obstacle and the blood will coming out quickly. So do not remove the instrument. And second point, you can identify the injured point, or you can identify the injured part immediately. If this is a very small needle, if I am keeping that at that place, at the injured part, I can identify that part immediately. If I am removing that, the blood will be coming out, and for bowel injury and bladder injury, I cannot immediately identify the injured part. Okay, so next step is leave that instrument at that place. That is same for also, because mostly for varus needle, for bowel injury, bladder injury, we do not require any intervention because this is very small entry and it will not cause any complications instead of any vascular injury. So for vascular injury, we might do intervention. But for every trocar injury, we have to do intervention. Suppose I am putting an trocar. This is very thick, 5 mm, 10 mm, 12 mm. So if I am putting that and I am seeing blood is coming out. So I am not removing that instrument. I am keeping that instrument at that place and I will do immediate laparotomy. And so that I can identify the site of injury and I can repair it immediately for blood vessels and for also bowel also, bladder also. If I will remove this instrument from the bowel, so I cannot identify the site of injury immediately after doing laparotomy. So it is very difficult to search for bowel injury. So keep that instrument in that place. So this is most important answer the examiner wants to listen. Next is bowel injury. So I have told you, keep the instrument at the same place. Do laparotomy if you can do. For bowel injuries, you can do laparoscopically, repair, do laparoscopically if you can do, or there is a large injury, then you have to do or need a colostomy, then do laparotomy and do the surgery. Same for bladder injury also. And how to prevent bladder injury? Put a Foley's catheter or empty the bladder. Bladder empty bladder before putting varus needle or trocar entry. Then another is subcutaneous emphysema and extraperitoneal insufflation. I have told that we are in the, if you are in the pre-peritoneal space, so this is the skin and this is the peritoneum. So if I am in the pre-peritoneal space and I am inflating or putting the gas, all the gas here, so the pre-peritoneal space will be enlarged and I will never reach when I will put the trocar, I will never reach the trocar cannot go. So I am all in the extraperitoneal space. So this is another complication. Suppose in case of pregnancy, what will do? So in pregnancy, conditions like acute appendicitis, cholecystitis, dermoid cyst torsion, we can do laparoscopic surgery in the late second trimester and third trimester. The primary port should be 1 to 2 centimeter below the costal margin in the left side, that is in the Palmer's point. So Palmer's point, I have told that during pregnancy we can do Palmer's point entry, and that is right or on the right side mid-clavicular line. Next instrument is port. So this instrument is a port. This is not trocar, this is not cannula. So this is a port. So this one is called trocar and this one is cannula. Okay. So this whole instrument is called as port. So there are various type of port. One is 5 mm operating, 10 mm for optical, 12 mm for robotic, and 15 mm for oscillator. I am holding a 12 mm. This is 12 mm. Sorry, 10 mm. Trocar. Sorry, port. Okay. So this is an optical trocar or optical trocar. Next is so the port. Port has two parts. One is trocar and another is cannula. So this is whole as called as port, and this is the cannula. This is cannula, and this one is called trocar. The trocar is inside. The trocar is sharp pointed. This one is sharp pointed, and see there is an eye here. Here there is an eye, and here there is an eye. See the tip. Tip is pyramidal. Pointed and pyramidal, and there is an opening here. So this from this eye, gas will enter and will do a hiss sound when we are inside the abdomen. The gas will come through this and come out from the outer part and will give a hiss sound, so that we can know that we are inside the abdomen. And next is, so this is called trocar. Another is, this is the cannula. See, this is the important part. For cannula, there are two parts. One is valve. This is the shaft. See, this is the shaft is open through and through, and there is a gas inlet. See, and valve. If the valve is parallel to the inlet, then it is open. If it is perpendicular to inlet, it is closed. So it is parallel, open, and it is perpendicular to the inlet, then it is closed. So this is the shaft. So there is nothing inside the shaft. This is only a through and through part. Next is, there is a valve. So this is the valve. See, this is the body valve. Inside it, that is a valve, and that valve keep the cannula closed to prevent the gas leak. So what is the function of this valve? The valve will prevent the gas leak. So if there is any problem with this valve, this is the valve, flap valve. This is the flap valve, and then there will be leakage of the gas during surgery. Another is, there is a outer cell is here. So this is the outer cell. See, this is the outer cell. Suppose there is also tear in the outer cell, so there will be continuous gas leakage will be because of this outer cell. So how will you remove? You will just rotate it. So there is a point here. So you just rotate it. So this is separated, and you clean it after surgery, and you just close it. So, okay. See, what are the types of trocar? See, this part, this is the tip. The tip is pyramidal. This is, see, this tip is like pyramidal tip. There are also conical tip. There are also blunt tip. There are also eccentric tip. There are different type of the trocar. More sharper the tip, there will be less chance of injury. Why? So during any laparoscopic surgery, when we are putting the trocar, so when we are putting the trocar, maximum injury is because of the momentum, because suppose there is a thick abdomen, the trocar is not going, then we will put more pressure to the abdomen, and when the air will enter into the abdomen, the resistance is lost, and suddenly will go inside and will hit the abdominal bowel and bladder and viscera or vessel. So the maximum part of the injury is because of the momentum. So because trocar will be pointed, so there will be less force will be required, so there will be less chance of the injury. So for in case of blunt trip, there is a maximum risk of injury in blunt trip. Blunt does not mean that it will not injure. It is at maximum risk because more force is required to enter into the abdomen. And for pyramidal trip, there is less force is required, so there is less chance of injury of bowel, bladder, and blood vessels. So this is the instrument, this is the trocar, and this is the cannula, and this is the outer cell. See the flap valve. This is the flap valve. I have shown you. Suppose during surgery, why gas is not retaining in the abdominal cavity? You are doing surgery. So first cause is the skin incision is very big, that is 15 mm. So gas is not retaining. Another cause is, most important cause is, there may be a problem in the inner cell or there might be a problem in the outer cell. How will you know? Suppose all the instruments are inside. So how will you know whether it is a outer cell defect or inner cell defect? Put all the instruments, laparoscopic instruments inside, and still the gas is leaking. So suppose this is the instrument. I will put the instrument and all the instruments, still gas is leaking. That means there is a outer cell defect. So you have to change the outer cell. But if you remove all the instrument, still gas is leaking, that means there is an inner cell defect. That means this cell is, you have to change this cell. Okay, so this is the inner cell. I will remove all the instruments and will see whether gas is leaking or not. If the gas is leaking, removing all the instruments from the port, then the gas is still leaking, that means the inner cell is defect. If I will put all the instrument inside of the port and see whether gas is leaking. If the gas is leaking, that means there is a defect in the outer cell. We have to change this outer cell, or this is rubber. Okay. Then is how to hold the trocar. The trocar is held like a gun. So this part, this is the opening. This part will remain at the thenar eminence. So this will close. I will close this part. This hole will be closed by the thenar eminence. I will hold the thenar eminence, and my ring finger, index finger, middle finger, and ring finger will wrap around the gas inlet. Then my index finger will pointing towards the sharp edge. So I will hold my thinner eminence. Then I will wrap around the gas inlet, and my index finger is pointing towards the sharp edge. So this is the correct position of holding. Then how I will do movement? My movement will be only pronation and supination of the arm. So pronation and supination of the arm will be there. There is no jerking movement, only pronation and supination. So this will cut the skin and subcutaneous fat and rectus and gradually go into the abdomen. Once there is a hiss sound, it means you are inside the abdomen. So gradually remove the trocar and you advance the port into the abdomen. Okay. Next important part is insufflator. So you must have seen this instrument or machine inside the OT during a laparoscopic surgery. There are 4 parts. This is one. There are 4 recordings. This is one. This is one. This is one, and this one. There are 4 recordings are there. The 4 recordings are, one is preset pressure. What is preset pressure? This is preset pressure. What is this machine first? The insufflator is a machine which insufflate or help in creating the pneumoperitoneum by insufflating gas into the abdomen. So which gas? Inert gas we are using? CO2 gas. Okay. So first is preset pressure. What is preset pressure? The command given by the surgeon. The command given by the surgeon to maintain the pressure. inside the abdomen. So suppose I am setting the preset pressure is at 10. So I am giving the command to the machine to set the pressure at 10 millimeter, 10 mmHg. And what is actual pressure? Actual pressure is the current pressure inside the abdomen. The actual pressure is current pressure inside the abdomen. What is the current pressure inside the abdomen now? Next is flow rate. Flow rate is 0.1 liter per year. Per year means suppose this is 1 year baby. So flow rate should be 0.1. Suppose it is 2 year baby. Suppose 2 year baby. So it is 0.3 year baby, 0.3. So for 10 year, it is 1 liter per minute. So for adult, we fixing it 6 liter per minute. That means in every minute it can enter 6 liter every minute. Next is total gas used. What is the amount of total gas intake? So one will be preset pressure, actual pressure, flow rate, and total gas intake. Some sequence might be changed in different machines. For diagnostic lab, we set the preset at 8 millimeter mercury. For operative, it is 12, and for obesity, it is 14. Okay. See, sometimes you must have seen that anesthetist will be telling to stop the procedure or to stop the creating pneumoperitoneum during surgery because of the some complications. Sometimes patient will have sudden fall of BP during creating pneumoperitoneum. Why? Because when we'll allowing much 10 to 12 liter or 15 liter per minute of gas into the abdomen, then there will be sudden creation of pneumoperitoneum. Then the vessels will be compressed. The IVC and aorta will be compressed. So once IVC is compressed, the venous return will be decreased. Once venous return will be decreased, and there will be decrease in BP. Patient will have tachycardia, sudden fall of BP. At the time, the anesthetist will tell you to stop the procedure or stop the pneumoperitoneum, and then they will stabilize the patient. So that it should be at a controlled manner. So for that, we have preset pressure, then actual pressure, then flow rate, and total gas used. Suppose during surgery, I have set the preset pressure at 8, and I have created the pneumoperitoneum. I will start to inflate. Now the actual pressure will be 1 or 2. Then gradually, as the gas will go inside, the actual pressure will be rising 4, 5, 6, 7, and flow rate will be also increasing. Once the actual pressure has reached the preset pressure, the flow rate will be stopped. The flow will be stopped because I have reached the actual pressure as the preset pressure set by the surgeon. So, for example, I have set the preset pressure as 10, and now and suppose I have set the preset pressure as 10, and I am insulating. So gradually the actual pressure will increase from 4, 5, 6, 7, 8 till 10. At 10 millimeter of mercury of actual pressure, the flow rate will be new. The flow will be stopped. So I have reached the reached the preset pressure. And this is the total gas used during the whole surgery. I will give some examples. Suppose for case 1, I have set a preset pressure of 12. The actual pressure is 6. I have not reached that pressure. There will be some cases. These are the cases in which you will be seeing there is failed pneumoperitoneum. There is failed pneumoperitoneum. The gas is not creating distension of the abdomen. Then what will you think about that case? Flow rate is 1 liter per minute, and total gas is you have entered total gas of 10 liter. Suppose you have entered total gas of 10 liter into the abdomen must be disturbed. But the abdomen is not is not created. That means sometimes you are either in the IVC. So in the IVC, the gas will be going. So there will be pulmonary embolism, and there will be death of the patient. So once you will see these four measures, then you can identify whether you are either correctly in the abdomen or any in the visceral structure or anything inside. Suppose the preset pressure is 12, actual pressure is 12. That means you have reached the actual pressure and flow rate is 0.5, and gas is also not going. 500 ml gas is insufflated, and now flow rate has been 0.5 liter. Why? That means you are in the pre-peritoneal cavity, that is extraperitoneal insufflation. Suppose you are here in the extraperitoneal space, so it will not be much distended. So it will be distended. It can have a capacity of maximum 500 to 1 liter. So the this is a closed cavity. So you have set the pressure as 12. Now actual pressure is have been reached because the closed cavity has been filled with gas. So that then you can think that I might be in the pre-peritoneal space. Suppose the preset pressure is 12, actual pressure has reached 12, flow rate is 0, and gas has gone only 200 ml. That means you are not in the abdomen, not in the peritoneal space, you are in the subcutaneous fat. So if you are in the subcutaneous fat, the gas will not go. So flow rate has been 0. You have, as flow, there is a closed cavity, the actual pressure has been, so in the machine it is showing 12, and the gas is not going. So in that way you can think you are in the subcutaneous plane. Suppose the preset is 12, actual pressure is 30, and flow rate is 0, and total gas is 200 ml. That means in which case, case, if the actual pressure is more than the preset pressure, then there is some occlusion in the Berry's needle. So think that there is some occlusion in the Berry's needle. So we remove the virus and clean it and again reinsert. So these are the few examples in which you can diagnose whether you are in the intra-abdominal cavity or not by only seeing this insufflator machine. These four recordings are very important, whether you can diagnose you are actually in the intra-abdominal cavity or not, or whether you are in bowel or bladder. If you are in bowel, the gas will be going into the bowel, and there will be distension of the upper part of the abdomen, not in the lower part of the abdomen, because you are inside the bowel. So you will be seeing the gas is going. Flow rate is there. The preset pressure is the actual pressure, but the actual pressure is not reaching. And there will be abdominal distension of the epigastrium, not in the hypogastrium. Then think that you are in the bowel. Suppose you are in the bladder. Then bladder has a capacity of 1 to 1.5 liter. You will see in the machine the actual pressure is reached after 1 to 1.5 liter, and the flow rate has been 0. And then you can think that you might be in the bladder. And then another, that is the, you can also know by, I have told you that the irrigation test, suction aspiration test. By that you can also know that you are in the, whether in the bladder or bowel or in the blood vessel. So this is about all about the insufflator, and we will discuss the rest of the instruments in the next video, laparoscopic instruments and other obstetric and gynecological instruments. Thank you.